Tracheostomy
It's a
is
very common all-round topic which I have heard from most of the students appearing. They say I was asked about tracheostomy, sir. So this is a very, very common scenario. So please pay attention and listen to this. Okay, go ahead.
So tracheostomy is making an opening in the anterior wall of the trachea and converting it into a stoma on the skin surface. Indication for tracheostomy is any upper airway obstruction caused by swelling, edema, infection, or tumor mass. Example in burns, anaphylaxis, and also in head and neck surgeries as an elective procedure. And patients requiring prolonged ventilation. This is the most common indication for tracheostomy. And to provide pulmonary toileting and to protect the airway where there is excessive tracheobronchial secretions requiring regular clearance by suction. So advantages of tracheostomy are it is an alternative pathway for breathing. It improves alveolar ventilation by decreasing the dead space by 30 to 50%. Also, it reduces the resistance to airflow, so as it decreases the work.
Alveolar dead space. What did you say?
It decreases the dead space, improves ventilation, alveolar ventilation.
Anatomical dead space is decreased, not
Yes.
the alveolar dead space.
Yes, sir.
You say which dead space? Anatomical dead
Yes,
space is decreased. Okay.
anatomical dead space, yes, sir. It protects the airway with the help of the cuff from secretions and blood. It helps in removing the secretions by suctioning, so we can avoid repeated bronchoscopy or intubation in such patients. It helps in also providing intermittent positive pressure respiration whenever required, and it has good prognosis in weaning when compared to intubated patients beyond 72 hours. So it also helps in administering anesthesia, especially in cases like laryngopharyngeal growth, patients with difficult upper airway anatomy and trismus. Disadvantages are, since we are bypassing the larynx, patient is unable to phonate, so they require a special device for speech. Loss of humidification and filtration function of the nasal mucosa, which resulting in increased risk of thickening of the secretion, basal atelectasis, and increased risk of respiratory tract infection. So mucus can accumulate above the tracheal opening, the larynx, which can trickle back into the lungs. Types of tracheostomy, based on the indication, it can be divided into emergency or elective tracheostomy. Based on the duration, it is temporary or permanent tracheostomy. Based on the technique, it is percutaneous dilational tracheostomy or surgical tracheostomy. Elective tracheostomy can be a therapeutic or a prophylactic tracheostomy. Therapeutic in case of, as I said earlier, upper airway obstruction or to remove secretions. Prophylactic in case of head and neck surgeries. Permanent tracheostomies are most commonly done in bilateral abductor paralysis, laryngeal stenosis, or a patient with total laryngectomy or laryngopharyngectomy. And by the level of tracheostomy, it is also divided into high, mid, and low tracheostomy. We usually do a mid tracheostomy, which is at the level of second and third tracheal ring behind the isthmus of thyroid gland. So technique of tracheostomy is it can be done under also local anesthesia and general anesthesia. If possible, endotracheal intubation should be done prior to tracheostomy. Position is a patient with supine neck extended by placing a pillow under the shoulders. For local anesthesia technique, 2% lignocaine adrenaline is infiltrated in the line of incision and also in the area of dissections. A vertical incision is made in the midline of the neck, usually in emergency cases. Which is extended from below the cricoid cartilage to above the sternal notch. And in elective cases, which the incision is a transverse incision, which is 5 centimeter long, to finger breadth above the sternal notch. It has a better cosmetic appearance. Tissues are dissected Strap muscles are separated in the midline and retracted laterally. Isthmus is displaced upward or downward. Then a few drops of 4% lignocaine is injected into the trachea before putting incision in the trachea to avoid coughing. So trachea is fixed with a hook and opened with the vertical incision. If the patient is under general anesthesia, the procedure is performed throughout with 100% oxygen. And during, if we use cautery while incision the trachea, we should switch off the oxygen. Then this vertical incision is converted into a circular opening and a tracheostomy tube of appropriate size is inserted. Skin should not be sutured very tightly. If we does, it will lead to a subcutaneous emphysema. Then the technique of percutaneous tracheostomy, it is usually performed by anesthesiologist or an intensivist as an elective procedure under fiber optic guidance. Initially, there were two techniques, which is a technique. It is a blind serial dilatation technique, and the other one is the guide wire with the dilating forceps, which is a Griggs technique. Nowadays, it is modified with under fiber optic guidance and a single step dilation technique. And the technique of percutaneous tracheostomy is a small transverse incision is made, blunt dissection with the forceps until the tracheal ring are felt. Based on the kit, we have a cannula. Usually a 14 gauge cannula is inserted. We have to aspirate air to confirm whether it is trachea. Also, we can confirm it by using a fiber optic scope. Then a guide wire is passed, then a dilator to dilate the passage, then the dilator is removed, then a tracheostomy tube is introduced with the introducer, then the introducer is removed and it is connected to the ventilator circuit and the position is confirmed. Contraindication for percutaneous dilation tracheostomy is whenever we require emergency airway access, difficult anatomy like a patient with obesity, pediatric airway, patient with short neck, cervical spine injury, and patient with moderate coagulopathy, local infection, we should avoid percutaneous dilational tracheostomy and we should refer to a surgical tracheostomy. Tracheostomy care in the post-op. There should be a constant supervision for bleeding, displacement or blocking of the tube, and we have to remove the secretions often according to the amount of secretion. Patient is given something for communication since they are not, they won't be able to talk. Use of humidifier if the patient is on ventilator like HME, or we have to instill few drops of saline and oral into the trachea every 2 to 3 hours to loosen the secretion. Also, we can use acetylcysteine solution or nebulization. Inner cannula should be removed and cleaned whenever there is a block or a blood clot, initially for the first 3 days. Outer tube should not be removed for the first 3 to 4 days until definitive tract is formed. After 4 days, we can even remove the outer cannula for removing the secretions and clots. Tube change. If the tracheostomy tube is with the inner tube, it should be changed every 7 to 14 days. If it is with inner tube, it can be placed up to 30 days. Without inner tubes, it should be changed every 14 days. Nutrition with tracheostomy tube. Ventilated patients can be fed using nasogastric tube or nasojejunal tube. Patient with tracheostomy be fed orally with the cuff inflated or partially deflated to avoid aspirations. That too after assessing the swallow of the patient. Complications of tracheostomy, immediate complications are aspiration, hemorrhage, air embolism, malposition, failure of the procedure, false tract formation, structural damage to the nearby structures. Intermediate complication are delayed hemorrhage, tube displacement, tube blockage, surgical emphysema, infection, tracheoesophageal fistula and dysphagia. Long-term complications are tracheal stenosis, patient will have problem with decannulation, tracheocutaneous fistula, cosmetic disfiguring scar, bilateral vocal cord paralysis. Weaning and decannulation, we have to assess the patient's neurological status. able to maintain adequate airway, patient has adequate respiratory reserve. If it is satisfactory, we have to assess the patient under video laryngoscope. We have to document whether the patient can swallow without aspiration. We have to document the mobility of the vocal cord. Then we can proceed with decannulation. If it is not satisfactory, we have to defer decannulation. Methods of decannulation are periodic cuff deflation or using a occlusion clap which completely blocks the tracheostomy tube, and we have to observe the patient for 24 hours for respiratory distress. And it should be performed in the operation theater. It should be equipped with re-intubation tray, difficult airway cart, smaller size ET tubes and tracheostomy tubes. After decannulation, patient should be observed for at least 24 hours. Problem with decannulation or persistence of condition for which the tracheostomy was done. Are there any obstructing granuloma, granulation, any edema or stenosis in the trachea, tracheomalacia, and psychological dependence? Emergency management of displaced or blocked tracheal tube. We have to recognize it early, call for senior help, and we have to attempt to maintain the airway. Based on the tracheostomy type, if it is surgical tracheostomy and if it is 3 to 4 days after the tracheostomy, we can remove the tracheostomy tube and there will be a mature trap. We can attempt once to reinsert the tube. If we are not able to do it, we have to maintain the airway from above by using bag mask ventilation, LMA or endotracheal intubation. If it is percutaneous dilatation tracheostomy, if it is more than 14 days, mature tract will be formed. We can try attempting once by reinserting it. Otherwise, we have to provide ventilation from above. If it is less than 14 days, if the patient is on ventilator, we can remove the tracheostomy tube. We can cover the wound, and we have to reintubate the patient, and we have to ventilate from above. Then speech rehabilitation for patient with permanent tracheostomy, it can be provided by artificial larynx, esophageal speech or tracheoesophageal speech. There is a Bloom Singer valve which has two advantages, which allows the patient to phonate, and also at the same time it prevents the saliva or oral secretions being aspirated into the tracheobronchial tree.
Okay.
That is all.
Very
Thank
good.
you, sir.
That's an elaborate description. Few points which I noticed to be added to this are, because you mentioned the surgical details, how to do the tracheostomy. The first and
Yes.
foremost thing after you make a incision is take a stay suture. I think you didn't mention that. That's a very, very important step because it will always help to identify the stoma in case there is a block or there is a difficulty in placing the endotracheal tube. This stay
Yes.
suture, which is including the skin, subcutaneous tissue, and the part of the trachea, will be taken first before you make the tracheal opening. Okay, and
Okay,
this
sir.
will help in closing the tracheal wound also after you decannulate. After when you plan to decannulate, this stay sutures will help to narrow down the opening, and it will help to clean that. And second important thing, which is nowadays very much insisted upon, is how do you confirm the correct placement of the tracheostomy tube after you have inserted it? What are the techniques? It is not only just the air entry and oxygenation. What are the other two standard confirmatory procedures that have to be carried out to find out the correct location of the tube? That it is neither into the bronchus nor very much above to slip out. It should be ideally placed above the carena. So that is the location you want it to be. So how to confirm the position?
Fiber optic bronchoscope.
Gold standard is you can insert a fiber optic scope and then go and see whether you are able to see the division of the bronchus and the carena. And
Yes, sir.
another accessory method is to see whether it is endobronchial or less invasive. Attaching an ETCO2 monitor. Okay, so that is also considered as one of the important things that have to be done. So as soon as you finish placing, before you connect the oxygen source or when the patient is spontaneously breathing, you attach the ETCO2 monitor line, side stream monitor can be attached, and that will show a normal graph and the normal value if it is not endobronchial. Otherwise, if it is endobronchial, patient may also have desaturation or reduced SpO2 plus PtCO2 value will also be not the normal. Okay. So these two tests are being done, are considered to be done as soon as you place the thing important. And with regard to the inner tube, it is not 14 days or 30 days. Actually, you have to inspect it 3 times a day because in a patient who is having a foreign body in the trachea, like tracheostomy tube,
Yes.
secretions are bound to be more. So there may be incrustations unless, as you said, if humidified oxygen is, or humidified air is not allowed to go through that. The normal humidifying mechanisms of the upper airway is lost. One of the disadvantages of tracheostomy, even though it reduces the anatomical dead space, it also prevents the normal humidification that is done by the nasopharynx and oropharynx. So the incrustations are more common. So the inner tube has to be uh, removed and at least inspected 3 times a day for any
Yes.
incrustations. And then how do you clean that? Supposing there are a lot of secretions which have become dried out and formed incrustations, how do you remove that? Any idea? This is of course a nursing work, but we should have some idea. It's cleaned with hydrogen peroxide and saline water. Okay, so that is how you clean that, and then you put it back into that, and uh, the uh, and all the other points like the complications, the uh, timing of the track formation, all these things are quite adequate. And, again, I will just share a presentation which may also have something for OSCE from that angle also.
Yes, sir.
Visible. So what are the indications for tracheostomy? She mentioned that can be divided into either it is emergency tracheostomy or elective tracheostomy. Okay. So the emergency tracheostomy is done mainly for acute upper airway obstruction, laryngeal trauma, or type of fracture in the maxilla called Lee-4-3 fracture, which will displace the maxilla and cause occlusion of the upper airway. And the elective tracheostomy can be done for prolonged mechanical ventilation. Patients whom you find it difficult to wean from the ventilator, you cannot keep them on endotracheal intubation for long because it will cause subglottic stenosis and other complications. So there is a debate on how soon to perform a tracheostomy if there is a difficulty in weaning. Some people say it should be done within the first week. Some people say not 7 days but 5 days. So there is a controversy going on, but it is left to the judgment of the treating physician. So the first and foremost indication is prolonged mechanical ventilation. The second is for patients who have copious secretions which are not easily removed through an endotracheal tube. You can do a tracheostomy for tracheal and pulmonary toileting. And patients who are suffering from neuromuscular disease, who have difficulty in breathing, they can be given a tracheostomy because it will help to reduce the anatomical dead space, and ventilation will be much better if they with their poor muscular effect. So that is one indication. Any subglottic stenosis, which also is an indication for that. And electively, it can be performed before any head and neck surgery or PM joint ankylosis with limited mouth opening. Some centers routinely do a tracheostomy and do the release and then recannulate the patient on the second or third day. But with the advent of fiber optic intubation, this requirement of elective tracheostomy for such cases is reducing to that cases also. And obstructive sleep apnea patients who are refractory to other treatments is also considered as a indication for tracheostomy. And the techniques of performing, it can be by open or percutaneous techniques, which you mentioned. Complications, which is a common question, it can be immediate and late complications. Intraoperative, that is while doing the procedure itself, you can have a severe bleeding because the isthmus of the thyroid gland is very close and it can be injured and you have another massive hemorrhage. And if the patient is receiving high concentration of oxygen and the artery is being used, you can get an airway fire and it can produce pneumothorax or pneumomediastinum if the catheter is not placed properly. And it can also cause acute obstruction, tube dislodgement, pressure necrosis, erosion, stenosis, and tracheoesophageal and tracheoinnominate fistula. This is another very dangerous complication which happens little later after this is mainly due to faulty inflation of the cuff, overinflation, which leads to too much of pressure necrosis on the soft tissues, leading to erosion, and that is the cause for that. So, what are the methods of assessing the correct placement of the tracheostomy tube? Is endoscopy allows for detailed assessment, capnography and cuff pressure confirm the tube is in trachea. The cuff pressure is given a lot of importance nowadays so that we don't either overinflate or underinflate to cause a leak. And what is the care that has to be given to tracheostomy? Yeah, clean the stoma frequently, change the bandage, change the ties, clean the inner cannula, use a humidifier, keep the patient well hydrated, and check constantly check for any problems, whether the patient has difficulty in breathing or desaturating or excess CO2 accumulation is having. All these things have to be taken care of. How often the inner cannula needs cleaning? Remove and inspect inner cannula regularly at least 3 times a day. Okay, this is a very important point that you have to remember. What are the three principles in the management of a blocked tracheostomy? Waveform capnography has a prominent role at an early stage in the emergency management. So you will not get a proper CO2, which is go to waveform. Oxygenation of the patient is a priority in this situation. And trials of ventilation via potential displaced tracheostomy should be avoided. Don't try to ventilate through the same tracheostomy tube if you suspect any obstruction in that. Suction is only attempted after removing the potentially blocked inner tube. Don't try to pass the suction through the blocked tube. Oxygen is applied that through the mouth and nose, potentially both airways, that is the upper airway. Simple methods to oxygenate and ventilate via the stoma are also described, where after removing the tube, you can flush the stoma with oxygen. A blocked or displaced tracheostomy tube is removed as soon as that is established. That is, once you are sure that the tube is blocked, remove it as early as possible and not as a last resort. Earliest removal will help in ventilating the patient. Now I am showing a few pictures here. Can you identify what is this?
Fenestrated tracheostomy tube with inner cannula.
Both fenestrated outside. This is also the fenestration in the outer tube. And this is a cuff. So you can say it is a cuffed fenestrated outer tube of the tracheostomy. This is the first one. The second one is a fenestrated inner tube. And the third one is the non-fenestrated inner tube. Okay, so these are all the three are there. Cuffed fenestrated outer tube tracheostomy, fenestrated inner tube, non-fenestrated inner tube. Can you identify this?
Cuffed and non-fenestrated tracheostomy tubes.
There's a long white tube going here in addition to the regular thing. Are you able to see that?
Yes, sir.
With the cap is also there, the blue thing. That is, of course, that is the pilot balloon and the inflation, but there is another long white tube. What is that?
Suction for
Suction for subglottic. Very good. Who said that? Sanjita? What is this? You can see some two markings here. This is the flange. This is the port for connecting to ventilator or this thing. So this is the pilot balloon and the cup. What is different from the,
Tracheostomy tube with the adjustable flange.
this is the length adjustable. Okay, so by
Yes.
putting this flange up and down moving, you can adjust the length that is to be introduced. So this is excellent. This is a adjustable length tracheostomy tube. What is PDT? Who introduced it and what is the equipment named after him?
Percutaneous dilational tracheostomy.
Very good. That is the expansion. Who introduced it? Of course, you said the name also.
Ciaglia.
Ciaglia. Yes, very good. Introduced by Ciaglia et al. In 1985. The equipment named after him is? What is the name of the dilator he introduced to expand the opening?
blue
Blue
rhino.
Rhino. Okay, it is called Blue Ciaglia Blue Rhino kit. Okay, so this is the entire thing. So manufactured by Cook Company. This is the entire set which is used for making the incision, guide wire, focal anesthetic. It's a comprehensive set with a serial dilator. This is called the Blue Rhino. This dilator, which is in blue color. Okay. Of course. So these are all the points. That are some of the points that we have to. All the other things what she described is more than enough to describe about that. Very good.